Hi, everybody. My name is Abe Korman. I'm an assistant professor of dermatology at Ohio State University. And today I'm going to be going through my approach to Kodachromes and just overall cases in dermatology. This is my first video on my YouTube channel, so go easy on me. I'm basically generating content on this channel aimed at dermatology residents to try to improve your ability to generate differential diagnoses, recognize unique features of cutaneous disease, and just become a better dermatologist. So this first presentation, this PowerPoint presentation, is a little less focused on actual Kodachromes. There are a few at the end, but more so a good approach and a good framework for approaching and attacking Kodachromes in cases that could be unknown or undifferentiated. So let's get to it. So I think the first thing one should do anytime you look at a Kodachrome or a patient comes into our office in real life is divide it into two buckets. You look at it and you immediately know it based on pattern recognition and your gut, or you don't know it and you have to go on to reaction pattern. So someone pulls up their sleeve, or you're looking at a Kodachrome, or you're on a board examination. You have that, microsecond gut feeling that you know what it is, and something immediately pops into your mind. That's number one. Stick with it. Often that's accurate. When you know that you don't know it, so we've probably always all been there, you kind of have that sinking feeling in your stomach where you look at something and you're like, I know this is something, but I don't know what. That's when you really need to rely on and lean on your reaction patterns in number two. Now, when you know something or you don't know it, I think it's always good to ask yourself, is what you think it is, based on what you think it is, does that match what you think it should be on your reaction pattern? So, for example, if you see a patient with pink, purple, scaly papules on the lower legs, and you immediately look at it and you're like, this is lichen planus. And then number two, you run through the reaction pattern where this is epidermal, papular squamous, lichen planus. You see that those both fit, and that makes a lot of sense. If they don't fit, then I think it's worth reevaluating your differential diagnosis. So let's go through the first one. So just some examples of pattern recognition. Then we'll go through reaction patterns, and then we'll do both. So we'll go through these examples of pattern recognition. So I'm going to put up a slide. I want you to think about what it is within a millisecond. And you probably will be able to do that. And that's kind of illustrating my point here. So this is psoriasis. And you probably look at this and within, half a second, you're saying to yourself, this is psoriasis. I doubt that anyone had time to say that this is an epidermal process given the scale. It's probably papular squamous and it's probably psoriasis. No one did that. So you're relying on your gestalt and trusting your gut. And I think that's extremely, extremely helpful. Sometimes that can lead you astray, but I think overall it's very accurate. And I think it's key to trust your gut. Next case. Probably within seconds, everyone, at least at the senior resident, is knowing that this is fixed drug eruption. Again, I don't think anyone is out of crust. Is this vesicular bullous? Yes, I would argue that's where you should put this in. And I would argue that's what makes reaction patterns fun. And this is what makes dermatologists great. Why the hell would someone say this is vesicular bullous? I don't see a blister. Well, you know that in superficial blistering diseases like pemphigus foliaceus, which this easily could be, or Derrier's disease, which, I would argue is looking at this and saying, well, let's see, there's no epidermal change, so this is dermal. It's kind of dusky, so it's probably an interface dermatitis. It's extremely well demarcated and oval, so it's fixed drug. That's all accurate, but you just don't need to do that in this case. You just know it's fixed drug from seeing it, from your pattern recognition, from your gestalt. So I think these are two good examples of where you can do this, where you can get away with this. But we'll move on to some where you have to lean more on your reaction pattern. So how about reaction pattern? So you see this slide, you might immediately have some ideas, but I would argue that this isn't really pathognomonic for anything, and you have to kind of think through it. So you look at this and you're like, I'm not sure. So if you're not sure, go to reaction pattern, and we'll go through this in a second. It's not the most fun thing to think about, but I think it's really helpful. You're looking at the periphery, you're seeing that this is scale. Scale means parakeratosis. That means you're in the epidermis. So you know this is an epidermal process. Then under epidermal, you can try to divide this up into other things. Is this eczematous, papulosquamous, vesiculobulous? Is it vascular? Is it a pigment abnormality? And you can see that this is most likely in the papulosquamous family. Papulosquamous, papulo means raised, squamous means scaly, so it's a raised scaly family. So you're immediately at epidermal, papulosquamous, and from there, you can either memorize or just learn from experience what some differential diagnoses are in that bucket. So you can learn the prototypic one of psoriasis, then, tinea corporis, lichen planus, parapsoriasis, CTCL. There's a million different diagnoses that can be in this bucket. In this case, it was tinea corporis. Again, same thing here. So you're seeing this guy, you're seeing that he has these expansive masses here on his nose and his upper cheeks. I don't think anyone could look at this and say, yeah, this is what this is. And it can be intimidating when you have a diagnosis like that and you're like, I actually have no idea what this is. That's okay. You don't need to know what something is, but you need to know where something is, or how to figure out what something is and how to approach it. So again, looking at this one, this guy has expansive plaques. You can see prominence of the pores on the nose, showing that there's expansion. You don't see any epidermal change, no scale, no crust, no blistering, no pigment, nothing. So you notice it's a dermal process. We'll go over in a second, but you can break down if something's dermal into inflammatory, neoplastic, or depositional. Do you think this is inflammatory disorder? Maybe. Maybe this is lupus. Do you think this is something neoplastic? Maybe. Maybe this is cutaneous T-cell lymphoma. Do you think this is something depositional? Maybe. Maybe this is amyloid. And so you can see from 3 buckets, you just generated 3 reasonable differential diagnoses. This ended up being none of the 3 things I just said. This is actually IgG4 related disease. But again, you're getting yourself to the right buckets: dermal, inflammatory, or dermal neoplastic probably. And then from there, you kind of know what you have to do in terms of biopsies, laboratory workup, etc. So reaction pattern, if you're down in this family where you just can't immediately recognize it, the first and most important thing to ask yourself is it epidermal or dermal? And how do you determine that? When people say, I think this is an epidermal process, what do they mean? They mean that there's something that you can see on top of the skin. There's scale, there's crust, there's blistering, the pigment's changed. And basically, if you don't see any of that, by definition, it's a dermal or subcutaneous process. So again, if you're looking at a rash, you're like, what is this? Look for these key features. And if they're there, you're in the scale family. In the epidermal family. If they're not, you're in the dermal family. Now, there are some exceptions and some things that can make this more challenging that we'll go through over time when we go through Kodachrome sessions, like secondary scale and things like that. But I think in general, this is a really good framework that you can work off of. So once it's epidermal, divide it into the family that you think it's living in. There's really only 5 families. So is it psoriasiform or papulosquamous? Is it bumpy and red? Is it eczematous, meaning does it look like eczema? Does it have small microvesicles and a lot of serous crust from the spongiosis leaking into the epidermis? Is it vesiculobullous? Are there blisters? Is it vascular? So is there redness, either redness that blanches in erythema or redness that doesn't blanch in purpura? And finally, is there a pigment abnormality? It seems kind of like a lot in the beginning to remember this, but once you have this framework for breaking down epidermal, it becomes really logical and really easy to develop a differential diagnosis and not just stare at something and say, I have no idea what it is. Because I've been in those, I've worn those shoes. I've been in those situations where maybe your first year or even the second, third year with some challenging diagnoses. And you're like, this is something, I just don't even know how to approach it. So put it in a bucket: papulosquamous, eczematous, vesiculobullous, vascular, pigment. From there, and I won't go through all of these, but from there, once you have it in a bucket, there's only so many differential diagnoses that lie in that bucket. So we did papulosquamous, right? So if it's epidermal and there's scale and they're well demarcated papules, it's papulosquamous. It's either psoriasis, lichen planus, tinea corporis, parapsoriasis, CTCL. There's probably more and more that I'm forgetting. There's a lot of diagnoses. Eczematous, it has to be some type of eczema. So either primary dermatitis, contact dermatitis. Is it id reaction? Is it photoallergic contact dermatitis? It's got to be in that family. Vesiculobullous, the most important thing is to divide it based on the split. Is it a tense bulla? Then it's probably subepidermal. If it's flaccid, it's intraepidermal. If it's super, super flaccid and thin, it's probably subcorneal. And again, in each of those families, there's a differential diagnosis. Vascular can be intimidating in the beginning, but again, it can be broken down logically. So if you can blanch it out, that means the blood is still intravascularly located, and that's an erythema. If you can't blanch it out, that means that blood is leaked out of the blood vessel, is sitting in the interstitium in the dermis, and very likely that kind of implies some type of damage to the blood vessels in the form of a vasculitis. Finally, pigment abnormality. Pigment abnormality, by definition, is going to be an epidermal process. That's where melanin, which is transferred from melanocytes to keratinocytes, is sitting. So breaking it down from there, you can kind of go into the hypopigmented or depigmented families. Dermal, like I had alluded to before, this is a simplification, but you can kind of put it into three different buckets. If you think something's dermally located, is it inflammatory, neoplastic, or depositional? And then you can break it down further from there. Again, this is obviously a YouTube video, so you can pause it and write this down or just try to memorize it. But again, this is a very logical framework upon which you can base your approach. Inflammatory, a lot of people kind of bring up the idea of basing your differential diagnosis on the cell line. I think this is helpful, kind of. There are some limitations to it, but I would say it is helpful in some scenarios. So, for example, things that are histiocytic really look reddish brown. So, sarcoid, deep GA, rheumatoid nodules, infectious histiocytic that really look reddish brown. Some of these other ones are a little less helpful. Lymphocytes and eosinophils can kind of look like anything. Is there any hint of interface dermatitis? So remember that case we saw, a fixed drug. Does it look dusky? Duskiness, violaceous appearance to a rash or a lesion is telling you that there is some type of inflammation at the dermal epidermal junction. And that's how you know there's interface dermatitis. Does it look neoplastic? And how can you tell if something looks neoplastic? It looks more fixed, right? You can tell that something didn't pop up overnight like something inflammatory could have. So does it look fixed and really dermally anchored? Then you can really get down the neoplastic route. It can be hard to tell what type of neoplastic, but there are some features. If something's very plum shaped and purple, you think about lymphocytes and lymphoma, maybe even things like Merkel cell carcinoma. If things look keratotic, you can think about keratinocytic keratinocyte carcinomas like SCC or BCC. Depositional. We'll have an example later, but depositional really has a unique look to it. So it looks like someone just took something and stuck it or injected it into the dermis. So you have an expanded epidermis. It looks non-inflammatory, non-neoplastic. And there are some classic examples of that are amyloid, gout, calcinosis cutis, osteoma cutis, etc. Now, just to complicate the matters further, and again, you don't have to memorize this, but you'll just learn this over time. There are miscellaneous reaction patterns that don't fit into any of those buckets we just discussed. And I really did want to highlight these because I think these make you an excellent dermatologist, a really good inpatient dermatologist, which is one of my focuses as well. So retiform purpura or livido racemosa. Retiform means net-like, purpura means blood. So you have a net-like deposition of blood inside the skin. And that means, by definition, the blood vessels had to have been screwed up. Something happened to them. There was some type of insult which led to extravasated blood vessels. So you know it's blood vessel wall issue. I can make a whole different talk on both of these diagnoses, but again, you see that pattern within seconds. You know this is something bad. The blood vessels of the skin are screwed up, and then that leads you down a whole differential diagnosis that we won't get into in this video. Ulcers, right? How does an ulcer fit into this? An ulcer is not really epidermal. It's not dermal, inflammatory, neoplastic, depositional, really. It's its own complete beast with its own differential diagnosis. And these are some ones I want you to know. And again, ulcers, we can make a whole entire video, and it's an own entire framework. But again, knowing how to approach it and approaching it systematically will lead to you not being, afraid or intimidated by these diagnoses anymore. You'll just attack it. So ulcers, with an ulcer, there's really only so many things that can cause it. And here they are. Is it an infection? Ecthyma gangrenosum, where you have gram-negative sepsis like Pseudomonas invading a blood vessel, choking it off, which leads to cutaneous necrosis and ulceration overlying it. Is it a primary blood supply issue? So does the person have a lot of really obvious existing venous disease? Do they have hemosiderin that shows you have stasis dermatitis? And they have poor blood supply, which leads to ulceration. Is it inflammatory? Well, how can you tell? It can be very hard to tell, but maybe in the beginning you see a really gunmetal gray, purple, violaceous inflammatory border that tells you that this ulceration is because of inflammatory cells that are killing the skin. Classic example being pyoderma gangrenosum. Is it depositional? So the classic depositional ulcerative disease is calciphylaxis, calcium depositing intravascularly, again, choking off the blood vessels, leading to overlying cutaneous necrosis. You can tell this with some experience where you see retiform purpura and ulceration that are completely non-inflammatory. It's just because something is choking off the blood vessels, kind of like pinching a garden hose and leading to the skin dying. Is it neoplastic? Long-standing neoplasms like squames and even BCCs will ulcerate. And finally, one thing to really consider is factitial. Does it look geometric? Does it look like an outside job? Is it in a weird spot? Is there a weird story to it? Again, we can make a completely separate in-depth video to ulcers, but I want you to know this is its own reaction pattern. I want you to know that you don't have to be intimidated by it. There's a way to attack it. So moving on, factitial and outside job is its own complete reaction pattern. If you see these geometric, weirdly shaped, non-responsive dermatoses, you have to think about these because they can be both epidermal and dermal in origin. Infection is its own beast. Infection, you can have an epidermal infection, tinea corporis, or you can have a dermal infection, angioevasive fungus, ecthyma gangrenosum with pseudomonas, etc. It's its own beast, so it should be kind of treated as such. There's this reaction pattern that doesn't really fit into anything in terms of hereditary, congenital, or disease specific. One of those things where you kind of see it and you know what it is, or at least that this is something or associated with some type of syndrome. So you see these vascular, blebs or purple nodules of blue rubber bled syndrome. You have these pink, very monomorphic papules on the bilateral upper malar cheeks. You think about angiofibrosis with tuberous sclerosis, things like that. Angiofibromas with tuberous sclerosis. So just knowing that there's some things that don't fit into these buckets. And then finally, there's some even more unique things. Pustular rashes. Yeah, pustules are epidermal and that they're neutrophilic, but they have their own differential diagnosis that you have to go through. Note that everything we've been talking about is skin. Dermatology is hard. We also manage nail, mucosa, and hair, and these all have their completely different reaction patterns. And then drug rashes are their own beast. Where do you put dress? Yeah, dress is probably dermal inflammatory interface dermatitis, but it's its own beast. Same with Stevens-Johnson syndrome, right? Stevens-Johnson syndrome, you could probably put in both. Epidermally, it's a vesicular-bullous disorder. Dermally, it's an inflammatory an inflammatory DEJ interface dermatitis. So these are hard, and I don't want to overwhelm you with these slides, but I want you to know reaction patterns will get you there. Things are hard, but you can always find a bucket. And if you can find the bucket, then you can research things. It's not uncommon. It's not shameful to tell the patient I need to step out of the room, or when you're on consults to just think hard about something. Use, your resources that you have once you have something in a reaction pattern. That's what makes you a good dermatologist. It's what makes you a good physician. So, just kind of to recap, you look at something, you know what it is, great. You don't know what it is, fine, let's put it somewhere. Is there scale, crust, blistering, pigment change, anything that's epidermal? If not, it's dermal. If you're like, great, it's epidermal, put it in a bucket. Eczematous, vesicular-bullous, papulosquamous, etc. If it's dermal, put it in a bucket. Inflammatory neoplastic depositional, is it a unique bucket? Is it retiform purpura, ulcer? Is it an infection, or is it something unique looking? And you do all these things, and you will get there, and you'll feel good about it, and you'll just make sure that you're taking good care of these patients. So let's go through some examples. So you can pause the videos. I want you to take a look at this. And the first thing I always want you to do is use your Gestalt. So within the first millisecond, few first seconds, say what it is. Physically say it out loud to yourself. This is so and so. And if you can't do that, that's okay, because you're going to then go through your reaction pattern. And I want you to practice it. So if you can't say what it is, go to your reaction pattern, epidermal, dermal. Go down those branching trees and get it to a place where you can at least make an educated guess. And then if you know what it is, challenge yourself one step further. If you know what it is, still go down those reaction patterns and see if you can get to the right diagnosis from your reaction pattern. If your reaction pattern and your Gestalt diagnosis don't match, something's off, right? Either your Gestalt diagnosis or your reaction pattern. All right? So here's the first case. Go ahead and pause it if you like to practice. I'm going to go ahead and just keep going through. So you might look at this and not have a Gestalt diagnosis. I don't know if I necessarily would. I would look at it. I would see it's annular. It's kind of uniquely annular. I don't see any epidermal changes. So there's no scale. There's no crust. So immediately I know this is dermal. Where are we? Dermal, inflammatory, neoplastic, depositional. I mean, these are broad annular patches, right? The odds that something neoplastic is causing this is low, although not unheard of. You can think about maybe CTCL, although there's no epidermal change. The odds that something depositional are causing this are very low. What's becoming deposited that's causing this dermal expansion in multiple places in weird annular arrays. So it's probably inflammatory. So it's dermal inflammatory. What type of inflammatory process do you think? I mean, what types of colors are you seeing here? You're getting kind of a reddish brown, maybe a little bit of a pink ruddy appearance to it of these annular plaques. So you're in the reddish brown category, which I kind of mentioned earlier is one of the ones that I do think is pathognomonic in being histiocytic. So your dermal inflammatory histiocytic. Do you know of any diseases that are dermal inflammatory histiocytic that are annular? Yeah, GA, granular annulare, and that's what this is. And maybe you knew this was GA, and that's fine because you could say within 2 seconds, well, these are annular reddish brown plaques without scales, it's GA. But then bring yourself there, confirm it, challenge yourself. Well, dermal inflammatory histiocytic, GA, GA on Gestalt, GA on reaction pattern. And that's how you know you're right. And you might not even have to diagnose this, or I'm sorry, you might not even have to biopsy this to look it up further. All right, next case. All right, so this case, again, you might look at this and be like, well, what the heck's going on? I see a blister, but where am I? Well, walk through it. Walk through it again. Blistering means your epidermal. So epidermal bullous. Where do you think the level of the split is here? This is a tense bulla. So you know this is subepidermal, which means you can throw out any diagnosis that is subcorneal or intraepidermal. They just don't make sense. Pemphigus vulgaris, pemphigus foliaceus, subcorneal pustular dermatosis, etc. So this is a subepidermal bulla. Now, we haven't gone into this further, and this kind of goes down how you have to go even more into the reaction patterns, more into the branches. But once you're in this area, one other important thing to ask yourself in blistering disease is it inflammatory or non-inflammatory? What do you see here? You see this large, very tense yellow to orange serous filled blister, and there's no really erythema around it. It's completely non-inflammatory. What does that tell you? That means whatever caused this is probably not the body. It's probably not something primary immunobullous. And you don't really have the history here, but they're showing you one large bulla. It likely means that they don't have a lot of other blisters, which means something that is going to be inflammatory, like bullous pemphigoid, mucous membrane pemphigoid, linear IgA, epidermolysis bullosa acquisita, which are all subepidermal blistering diseases, are going to be unlikely. The other thing is those are all, except for maybe EBA, inflammatory. So without inflammation, that's going to be very unlikely. So you're in epidermal, vesiculobullous, subepidermal, non-inflammatory. Now, this just takes knowledge and time, but once you get there, you'll know what lives in that bucket. And a few things that could be there. Bullous arthropod, just a really bad bug bite can give you a subepidermal blistering reaction that's non-inflammatory. Bullous contact dermatitis can be non-inflammatory. Is this an edema bulla? Is this a hospitalized patient? Note that you see the gouge, so the answer is probably yes. Is this a coma bulla? You have a lot of answers now that make sense, and this one ended up being a bullous arthropod reaction. So next case. Again, I would challenge anyone to look at this and say this is XYZ diagnosis, but knowing where this lives is going to get you the right diagnosis. So what reaction pattern is this? We've been discussing epidermal, dermal, and then breaking it down, dermal, inflammatory, neoplastic, depositional, but this is going to be one of those unique ones that I mentioned on one of the latter slides that does not necessarily fall into any type of bucket. So immediately you should be able to recognize and train yourself with time to know that this is retiform purpura. Retiform means net-like, purpura means blood. So again, you can see that this has this branching stellate to retiform appearance. Here you can see a purple to violaceous color that tells you it's purpura. It's almost certainly infiltrated purpura with eschar here telling you that the skin has died. So you're in the retiform purpura differential. I won't go through all that from time, but this diagnosis is calciphylaxis. Some clues that can get you there. We're on a thigh, so we're in a fatty area. So retiform purpura in a fatty area, especially in the right patient, like a patient with end-stage renal disease, is going to be highly concerning for calciphylaxis. Of course, you absolutely cannot diagnose this without tissue and more history and things like that. This could be 20 other things that we can go through on a retiform purpura video. But again, the most important thing is when someone shows you this photo, or say someone pulls up their gown, or you're in the hospital, immediately knowing this is something serious. This is retiform purpura, and this is something bad. And over time, this won't be intimidating. You'll see this, and you're like, oh, crap. Now I have to do a lot of work with biopsies and stuff. But you know immediately what you have to do. 2 biopsies, telescoping deep to fat, H&E cultures, and lab workup. Again, we'll go through in a different video. So this is the next case. This is the heel of a kid. So you look at it. Some of you might have immediately known it. If you don't, then yeah, you will with time. And this is calcinosis cutis. It's like a heel stick calcinosis. But again, get there. If you can't get there with Gestalt, there's no epidermal change, right? This is clearly an embedded structure. There's no scale. There's no nothing. So it's dermal, inflammatory, neoplastic depositional, there's no inflammation here, right? There's no erythema. There's no marker of any cell here. Neoplastic, this is clearly something acute. There's nothing expanding the dermis. Depositional fits very well, right? It looks like someone just took something and plucked it in there, and that's what they did, right? It's heostatic calcinosis. Someone took the baby's glucose and stuck it with the needle, and calcium um, kind of got deposited here in abnormal tissue. It's a form of dystrophic calcinosis cutis, not too dissimilar to calcinosis cutis in the setting of dermatomyositis or scleroderma or whatever. So again, you probably knew what this was, but again, if you don't, you can at least get there. It's dermal, depositional. Oh, I guess it's white, chalk white. This is probably calcium. This is calcinosis cutis. Next slide. So take a second, see what you think. Again, I would wager that the vast majority of you looked at this and said this is carp, right? So you see these reticulated, thin, reddish brown, scaly macules and patches on and in between the breasts of a woman. So that's really good for a carp. But again, if you can't get there, if you don't know it, then find it. You see that there's thin scale here. It might not come up perfectly on slides, but you know it's epidermal. So it's an epidermal process. From epidermal, you could break it down further you know, um, into whether you think it's papillosquamous, eczematous. I would argue that this is probably best as a papillosquamous eruption. So again, it's raised and scaly. And then from there, you can walk through the differential diagnosis and get there. There's no erythema for psoriasis. It's not annular and clearing for tinea corporis, et cetera. You just run through a differential diagnosis and get yourself to the right bucket, get yourself to the right answer. So here, this is a cutaneous horn. Again, cutaneous horn is kind of its own bucket, but what is a cutaneous horn? It's a massive extension and expansion of the stratum corneum, right? Due to something in the epidermis causing overlying proliferation. So this is an epidermal structure. It's usually due to some type of epidermal tumor. That could be a benign one like a wart or seborrheic keratosis, or malignant like an SCC. So cutaneous horn, epidermal proliferation, it's either a malignant entity or a benign entity, and you immediately know how to approach it. Look at this case. There's some of you who might immediately have a Gestalt kind of feeling for what this is, but if you don't, it's okay. It's okay. You could break this down. So pause it and think about it. So moving on with this, over time, you'll train yourself. If you see kind of these plum-shaped, broad pink patches, and this is the butt and the buttocks, especially of a white man, you really, really want to worry about CTCL, cutaneous T-cell lymphoma. And you might know that, and that's great. It's good that you know that. But if you don't know that, how can you get there? It's tough because there are some areas where you might say that this is an epidermal process because there's a lot of scale here. So maybe you go down that route and you say that this is epidermal. And under epidermal, you're probably going to be in the pap squame, right? Because it's raised and scaly, raised and bumpy. So you're going to be in pap squame, which brings you to psoriasis like in planus, CTCL, et cetera. And you can get it that way. Now, a lot of the scale that you see in CTCL is often secondary. So you might end up in a different pathway. You might be going dermal. And dermal inflammatory neoplastic depositional. It's not depositional, right? What's causing this depositionally? I can't think of much except maybe in a younger patient, someone is injecting themselves and you're getting silicone granulomas. That could be a thought, but that's really going to be inflammatory histiocytic anyways. So you're going to be inflammatory and neoplastic. And inflammatory, you have these pink to reddish brown areas. So you're ready in the lymphocytes to histiocytes, some type of inflammatory proliferation of lymphocytes or histiocytes. Neoplastic, you can definitely go down that route for the same reason. So you're in the inflammatory / neoplastic dermal or papillosquamous epidermal. And to be honest with you, CTCL is both. So you're right in the right bucket. So you might not know what it is, but you know where it is.